Now, a new strawberry-flavored antiretroviral is expected to arrive in the country. The new medication brings with it more hope for the treatment of HIV-positive children. Joining me now is Dr. Leon Levine, Senior Pediatric Advisor at the health NGO Right to Care. He's been treating children with HIV for over 25 years. Thank you so much for your time this evening, Doctor. Now, this new drug is seemingly the answer for the issues around getting children to take this medication. Maybe let's start with how it's been manufactured.
Good evening, Slindelo. Yeah, actually, there's two medications we're talking about, both strawberry flavored, so it's a bit confusing. And there's two. The one is what we call dolutegravir, the pediatric dolutegravir. Now, dolutegravir is this new antiretroviral that's taken the whole world by storm. We've had it in this country for adults since 2019, but it's been limited to pediatric patients over 20 kilograms. So now with this new formulation, we can take it right down to 3 kilograms and 4 weeks of age. So that's fantastic, and we're probably going to find most of our young pediatric patients are going to change to that. And the other one is what they call the 4-in-1, which is basically the same as what they're taking at the moment, but in instead of being a terrible syrup and 3 different medications, it's one medication, a powder which is just mixed with liquids or solids, and it tastes delicious as well. And the problem with the one we've had at the moment is it tastes absolutely vile, and a lot of these children are just not taking it or spitting it out or vomiting it. So it's really been a terrible situation for these young children. The ARVs we've had up to now are pretty good, but we just cannot get the children to take them.
Dr. Levine, maybe then just take us through the numbers. In South Africa, how many children are we looking at that have tested positive for HIV, and the kinds of treatment that is available for them? You've mentioned the 4-in-1, but is it really effective for them?
Yes, no. So it's definitely effective. I mean, the 4-in-1, the actual same medications we've been using for many years now. And children have done pretty well on it, and it's just not all of them do well because they can't take their medication. They spit it out, but there's nothing wrong with it. But the pediatric dolutegravir, which we are going to change virtually all of them to now, is actually even better, very well tolerated. It's going to be a once-a-day treatment, whereas at the moment what we have is twice a day, which is very difficult for young babies or even for school children, teenagers. Very difficult to do twice a day. Whereas the adults, have got 1 tablet a day. So now with this new formulation of the dolutegravir, it will be once a day, which will really be great. Once a day, well tolerated, easy to take. And in fact, there's another new formulation which is already available, which combines the other 2 medications. But remember that antiretrovirals are always going to be 3 different drugs. So the other 2 are also combined together in another tablet. So it's just going to be 2 types of tablets that they'll take once a day, which is really going to be phenomenal.
Dr. Levine, you've been treating children for over 25 years. Can you maybe walk us through some of the changes in care when it comes to children with HIV?
Yeah, Slindelo, it's actually interesting that for a long time there's been very little change. For many years, it's been the same medications. We've had these medications for years and years and years. And just suddenly, in the last few years, there's been this surge of new medications. And now we're having 2 medications at the same time. And it's been phenomenal. But the strange thing is that there hasn't been a major change. There's been very little new development of pediatric drugs. Children, as you know, always sort of lag behind the adults because no one wants to test new medications on children. They first test on adults and wait for years and years and years, and our children can't wait. They're dying. We have to get them on treatment as soon as possible. And now with these 2 phenomenal drugs, but even then we're behind. The adults, remember, started in 2019. We're going to probably start with the new dolutegravir going to be next year in 2023. So it's still a good 4 years behind the adults, which is not ideal. But I'm just happy that it's happening.
Yeah, let's just continue on that issue, Dr. Levine. I mean, you say that it's quite difficult to not only give this kind of medication to children. You've mentioned how the one that we have right now, the 4-in-1, doesn't taste too great. Do you find that you're going to have issues convincing parents to switch to these 2 new options?
Just a little correction, Lindela. The 4-in-1 is actually the good one. The 4-in-1 is replacing 4 separate medications that we have at the moment, but the 4-in-1 is actually tastes delicious. So that's the good one. So the 4-in-1 probably won't be used much because this pediatric dolutegravir is going to take over, and there'll be very few patients who will be on the 4-in-1. But that 4-in-1 tastes delicious compared to what we have at the moment. So I don't think it will be difficult to convince the parents. Not at all. I mean, the kids hate it. They really hate it. And the parents can see that they hate it, and it's a struggle. I think we might have, certainly in the Department of Health, in our clinics, I don't think there'll be any issues because there's new guidelines that are being developed as we speak, and the new guidelines will incorporate all these new medications. So there won't be any issues. The parents will be happy. The caregivers, the nurses, the doctors will be happy to do it. Where I think there may be a problem would be the private sector. Because for some strange reason, the private sector doesn't have guidelines like they have in the government sector. And people sort of do their own thing, and they've got this attitude out there, if it's not broken, why should we fix it? And they'll leave these children on terrible tasting medications. You know, I might add, they drive the fanciest, latest model cars, and their cell phones are the most updated models, but the medication they prescribe to the children are very outdated, and that may be a bit of a challenge. In addition, there's going to be a lot of education. Certainly at Right to Care, we're going to be rolling out lots of training, webinars and face-to-face trainings on the new guidelines, on the new formulations. So there'll be a lot of information out there, and I can't see there to be any problems with the parents as long as they know about it. So parents should be empowered to go into the clinic and say, I would like to put my child on the new medication because that's what it's there for.
Mm. Can you tell me more about how the medication is being procured, the efforts from government? Is there a partnership with the private sector, perhaps?
Right. So the first star in the story is SAHPRA, South African Health Products Advisory, if I don't know if I've got it correctly, but SAHPRA, who pushed through the registration of both of these drugs, which is phenomenally, really amazing at rapid speed. You know, historically, there have been issues with them taking long times to register, and they were phenomenal. And we were working together with them, government, us as NGOs, the South African HIV Clinician Society, we're all working together with SAHPRA to push the registration of that. And now that they are registered, we now have to get them onto tender, because a new government tender has just come out in July. But the problem is you can't put a drug onto a tender unless it is registered in this country. And because they weren't registered yet, they couldn't be put up for tender. So now they will probably put up what they call a supplemental tender, which is a new tender. It does take a couple of months to do, but then we will then hopefully have both of these formulations available. I'm not sure exactly when. My estimate would probably be sort of early next year, but I may be wrong.
Yeah, Dr. Levine, of course, for many South Africans, getting treatment is quite expensive. I'm assuming these will be available in government institutions?
Absolutely, absolutely. They'll be available in government institutions, and as you know, they don't have to pay for it. In private, they will be available. I'm not sure about the pricing yet. They will probably be a little bit more pricey than what we're paying at the moment, but the medical aids will all pay for these medications as well. So the only people who will be struggling, those who are private patients who are not on medical aids, but then they can definitely go to the government clinics and get it for free. So they should be available, and especially dolutegravir has been rolled out in the whole world. I mean, Africa has been using it for years, long before we started using it. So these drugs have been phenomenal, and we are seeing these patients get control, what we call suppress their viral load, where previously they were struggling to do it. So we're hearing great news in the rest of Africa. We're just waiting for us to roll it out here, and it's going to be phenomenal. The 4-in-1, if I could just say something, is also a bit of a landmark, because the 4-in-1 is only registered in one country in the world, and that is South Africa. It's not registered in any other country, and that's all due to the efforts of SAHPRA, who registered it when it's not registered yet in the United States or in Europe. So we are the leaders in terms of that medication. Yes, it's not going to be the main medication we'll use, because we'll be using the dolutegravir. But for those who are not tolerating the dolutegravir, or dolutegravir stops working, we'll have this phenomenal 4-in-1 that we can use for them as well.
Maybe then talk me through, Dr. Levine, the difficulties of telling a child that they have HIV. How do you help them manage the emotional issues, that come with it?
Right. So yeah, it is difficult. Obviously, we've been talking about young children now. These will be older children from school going age upwards. When we talk about disclosure, there's two kinds of disclosure, what we call partial disclosure, where we explain to the child exactly what's going on, but without giving them the name. They only really need to know the name at the time just before they become sexually active, when obviously they need to know the other issues that regard HIV in terms of not passing it on, using condoms, that kind of stuff. So, but partial disclosure you can do from relatively young children, and you would ideally want to have full disclosure done really between the ages of 10 and 12. The problem, Sindelo, is not really the children. The children are phenomenal with it. It's the parents, because the parents are scared, they feel guilty, they don't know much about this disease, they're scared the child will start asking questions that they can't answer. And so it does become difficult, and for that reason, parents block and don't want to know it. And I know some of my private patients, they'll all of a sudden, sorry, the mom can't come today, or in the old days, when I said, I think next time we should tell the child, they just left me, left my practice. Till I realized, I said, look, I will never force you to tell the child. We will always only do it when you're ready, and we've remedied that. But it's difficult, and I think it's very hard for the parents to do it alone. And remember, us as healthcare workers, we are also scared. Look, I've done over 100 of them. I could do them in my sleep. There's a technique that we've developed at Right to Care, which is phenomenal. It works really well. But most people out there are so scared. So what do they say? It's your job to the parents. The parents are scared, so they don't do it. And it just doesn't get done. And then what happens? The children go to Dr. Google their medications, and then they read all the worst things about the disease, and that's a disaster. So we've got to get in there. And I could just say, if you are a parent of a child with HIV, speak to your healthcare worker long before they turn 12. I've had some patients where the parents don't want to go and do it until they're 18. But sometimes the parents need the counseling, the parents need the therapy until they are ready. And if you recognize that, go and ask for help, and don't do this on your own. Let your clinic or your healthcare worker help you to do it. It's a choice of what role they take. You can do everything, they can be present. They can do everything, you can just be present. Or you could be, between both of you could decide what roles you want to play. So there's a lot of work to be done before it's actually done. And disclosure is actually a process. It's not a one-off thing. Hello, you've got HIV, goodbye. It's a process that starts long before you give the name of the disease and continues long after you've given the name of the disease.
Dr. Levine, I wish I had more time with you. However, we have run out of time. Thank you so much for giving us more insight on the developments in terms of care for children with HIV. That is Dr. Leon Levine.